Hi and good day everyone. My name is Wan Rohaida from Group 11. Our group will discuss a case from the reproductive system which is polycystic ovarian syndrome. Without further ado, let's move on to the case scenario. Miss HRY, a 22-year-old female, presented to the hospital with a 6-month absence of period. She has a history of irregular menstrual cycles since menarche, but this is the first time she has experienced such a long gap. She has also noticed a significant increase in her body weight over the past few months. Also, she is concerned about excessive facial hair and hair growth on her chest. She experienced menarche at age of 11. She has been visiting a dermatologist for acne treatment since the age of 15, and while it was under control initially, her acne has worsened on her face and the back over the past 2 years. Currently, she is using topical antibiotic for acne and taking multivitamin for supplement. She has no past medical and medication history, also no allergies. During general examination, her BMI is 29.1, which is considered overweight. Her blood pressure and heart rate are normal. However, she has hirsute and acne on the face and the back. Also, she has no acanthosis nigricans. For family history, her mother had gestational diabetes mellitus previously, and her elder sister has PCOS since 2 years ago. For social history, she is full-time university student, non-smoker, non-drinker, also sexually inactive, and no previous pregnancies. This is the lab data. All parameters are normal except for luteinizing hormone, which is slightly higher than normal range, and testosterone level at the lower border of normal range. For oral glucose tolerance test, the glucose reading at 0 hour is 6.1 ml per liter, which is considered impaired fasting glucose. And after 2 hours, the reading is 9.1 ml per liter, which is considered impaired glucose tolerance. For insulin, the level is high for both readings. Other than that, her transrectal pelvic ultrasound showed bilateral polycystic ovaries, and the diagnosis is PCOS.
I'm Wang Weijing. Now I will start with question 1 to explain the physiologic anatomy of female reproductive system with diagram. Let's start with the external female genitals. Mons pubis is a pad of fat located at the anterior of pubic bone, which is covered with pubic hair after puberty. The function is to protect the pubic bone from trauma. Labia majora is the folds of the hair-covered skin located at the posterior of mons pubis. The function is to protect the external genital. Labia minora is located inside of the labia majora, surrounding the vagina and uterus. Clitoris is the meeting point of two labia minora, which is a small and sensitive protrusion. Thus, it is important for sexual arousal and pleasure for women. The vagina opening is the exit of menstrual blood and baby, which is located between the opening of anus and urethra. Lastly, the hymen is a piece of tissue covering the opening of vagina partially to allow the menstrual blood and other secretion to excrete out of the body. Let's continue with the internal female genitals. The vagina is a muscular canal that joining the cervix to the outside of the body. It is flexible and can be expanded to accommodate childbirth and intercourse. The vagina is lined with mucous membrane to keep it moisture. The cervix is narrow and located at the lowest portion of the uterus that connect to the vagina. It produces mucus to facilitate the sperm movement during ejaculation. Next, the uterus is a hollow, pear-shaped muscular organ that nourishes and grows the fetus during pregnancy. The wall of uterus contains 3 layers, which are endomedium, myomedium, and perimedium. The muscle fiber of uterus are able to produce powerful contraction, which facilitate the labor, and less powerful contraction to expel the menstrual blood out. The ovary is almond-shaped with grayish-white color. It is located between the pelvic cavity and attached to the uterus via ovarian ligament. Each ovary is divided into 2 zones, namely inner medulla and outer cortex. Lastly, the uterine tube, which is also known as the fallopian tube, is a pair of muscular tubes with a funnel-like shape. The uterine tube is located near the ovary but not directly connected. It consists of a small projection to pick up the released ova and the cilia to transport the ova to the uterus.
Hi everyone, I'm Teng Chi-Feng, and now I'm going to proceed to question 2 with diagram explain how menstruation occurs. So menstruation is basically divided into 3 phases. The first one is the menstrual phase. So in this phase, the endometrium lining undergoes shading, and it occurs during the early days of follicular phase of ovarian cycle when the progesterone, FSH, and LH remain low. The reduction of progesterone is due to the degradation of corpus luteum, which is the ending of the luteal phase. This in turn triggers the shedding of stratum functionalis of endometrium. So before menstruations, the vasoconstriction decreases the nutrients transportations to the endometrium. Necrosis will then be initiated and slowly, the necrotic endometrium will separate from the uterus until all the superficial layer are shed. The mass of tissues and blood filling in the uterus cavity, together with the contractile effect of prostaglandins, initiate the uterine contractions and thus experience the uterine content, producing menstrual flow. The second phase is the proliferative phase. So at this point, only a thin layer of epithelial cell remain. So when granulosa and Tecal cells of the tertiary follicle starts to produce more estrogen, the stroma and epithelial cells proliferate rapidly, stimulate the restoration of the endometrial lining. The endometrial surface is rebuilt within 4 to 7 days after the beginning of menstruation. Hence, when ovulation occurs, the thickness of endometrium is approximately 3 to 5 mm. Now moving on to the last phase, which is the third phase, secretory phase. So after ovulation, the progesterone and estrogens are secreted in high amount by the corpus luteum. This will further contribute to the development of endometrium thickness. Progesterone plays a stronger role than estrogen as it causes a marked swelling and secretory development of endometrium. The secretory phase reaches the peak about 1 week after ovulation when the endometrium achieves thickness of 5 to 6 mm. The endometrium is now well prepared for implantation. Over the next 10 to 12 days, during the period when fertilized ovum enters the uterine cavity until implantation occurs, the endometrium glands secrete a fluid rich in glycogen which function as nourishment for the dividing ovum. After implantation, the endometrium will be digested and the stored substances in the endometrium will be used as source of nutrients for the implanted embryo. So if fertilization does not occur within 10 to 12 days, corpus luteum will degrade into corpus albicans. Estrogen and progesterone levels start to decrease and eventually enter the menstrual phase, and this indicates that next cycles begins. Moving on to question 3, what is amenorrhea and what are causes? So basically, amenorrhea means the absence of menstruation during the reproductive period of a female's life. The most common cause of amenorrhea is pregnancy, thus pregnancy must be ruled out in all amenorrhea cases. This is because the physiological conditions of amenorrhea includes pregnancy, lactation, and menopause. So amenorrhea is basically divided into two types. The first one is primary amenorrhea. So it means the absence of menarche by age 16 with normal pubertal development, or by age 14 in the absence of normal pubertal development, or 2 years after the completion of sexual maturations. While for secondary amenorrhea is the absence of menstruation for at least 3 cycles of at least 6 months in females who experienced menstruation previously. So, normally the causes of primary amenorrhea include anatomical defects, elevated FSH levels, hyperprolactinemia, hypothalamic amenorrhea, PCOS, hypopituitarism, weight loss, anorexia nervosa, and isolated GnRH deficiency. While for secondary amenorrhea is commonly caused by pregnancy, hormonal disturbance, physical damage or blockage, and blockage of outflow of menstrual blood.
My name is Tachani Virsu, and I'll continue with question number 4, which is the function of ovarian hormone. At the uterus, estrogen promotes the marked proliferation of the endometrial stroma. It increases the size of the uterus and development of external female sex organs. Additionally, estrogen stimulates the growth of the endometrial gland, whereas progesterone promotes secretory changes in the uterine endometrium. It decreases the frequency and intensity of uterine contraction. Moving on, in the fallopian tube, estrogen induces the proliferation of the glandular tissue on the mucosal lining. It enhances the activity of cilia by increasing the number of ciliated epithelial cells, whereas progesterone increases secretion by the mucosal lining of the fallopian tube. At the breast, estrogen is responsible for developing stromal tissue and depositing fat in the breast. It initiates the growth of the breast and the milk-producing apparatus. Furthermore, estrogen promotes the growth of the ductal system. At the contrary, progesterone promotes the development of lobules and alveoli in the breast. It stimulates the proliferation, enlargement, and secretion of alveolar cells. In the skeleton, estrogen inhibits the osteoclastic activity and stimulates bone growth. It plays a vital role in maintaining the bone density and preventing osteoporosis. In terms of body metabolism and fat deposition, estrogen increases the overall metabolic rate of the body. It influences the fat distribution by depositing fat in the breast, subcutaneous tissue, buttocks, and thighs. In terms of hair distribution, while estrogen has a slight effect on hair development, it primarily affects hair growth in the pubic area. The main hormone responsible for hair development is androgens. In terms of skin, estrogen promotes the development of soft and smooth skin texture. It increases the vascularity of the skin, resulting in a warmer sensation. In terms of electrolyte balance, estrogen rarely causes a slight effect on sodium and water retention. In some cases, it may lead to fluid retention during certain periods. Next is question number 5, the pathophysiology of the polycystic ovarian syndrome. Gonadotropin-releasing hormone is released from the hypothalamus. GnRH will travel to the anterior pituitary and stimulates the release of luteinizing hormone and follicle-stimulating hormone. The LH and FSH will travel to the ovary where they exert the effect on the thecal and granulosa cell respectively. Thecal and granulosa cell produce the estrogen and progesterone before and after the ovulation. Progesterone produced after the ovulation can reduce the release of GnRH through a negative feedback mechanism. These help to regulate the hormonal imbalance. In PCOS, follicle fail to ovulate, resulting in the absence of the corpus luteum and surge in the progesterone level. This leads to increased release of GnRH from the hypothalamus. Due to excessive release of GnRH, the LH will surpasses the FSH level. Lack of the FSH leads to failure of the follicle maturation, resulting in the formation of the ovarian cyst. High level of LH will stimulate the thecal cell to produce more androgens, further complicating the hormonal imbalance. Insulin also plays a role in PCOS. Insulin released from the pancreas can stimulate the steroid genesis in the thecal cell and adrenal cortex, increasing in the androgen production. Androgen will complicate the hormonal imbalance by exerting negative feedback on the hypothalamus and pituitary gland, making the ovulation difficult to occur. Androgen reduces the insulin sensitivity, leading to insulin resistance. This forces the body to secrete more insulin, which further stimulates the thecal cell to secrete even more androgens, and this cycle continues, leading to the PCOS.
My name is Yu Siwei. Question 6. How to diagnose polycystic ovarian syndrome? 2 out of 3 of Rotterdam criteria needed to diagnose PCOS. First is oligo and ovulations. Is ovulatory dysfunction in which oligomenorrhea takes more than 35 days but less than 6 months between 2 cycles, or amenorrhea which absorbs menstruation for 6 to 12 months. Next is hyperandrogenism, with presence of excessive acne, hirsutism, high testosterone level, or dehydroepiandrosterone sulfate. Last is polycystic ovary by ultrasound. That means ovary contains 12 or more follicles measuring 2 to 9 mm diameter or volume more than 10 ml. Androgen excess should be present with oligomenorrhea or polycystic ovary morphology, or both, to confirm the PCOS. Other conditions that might make PCOS like thyroid disease, non-classic congenital adrenal hyperplasia, hyperprolactinemia, and androgen secreting tumors should be ruled out. There's variability of using PCOM to diagnose PCOS, especially in virgin or obese patients, because it's hard to count intrafollicle transabdominally. Hence, serum anti-Mullerian hormone is more sensitive than intrafollicle count because pre-antral and small antral follicles are reflected, which is hard to be seen in ultrasound. Question 7. Discuss the clinical presentation of this patient. First is oligomenorrhea. Is irregular menstruations caused by an ovulation in which menstrual cycle is more than 35 days or 4 to 9 menstrual cycles in a year. Next is amenorrhea. An ovulation is normally accompanied with secondary amenorrhea after period of variable oligomenorrhea. Is the absence of menstruations for more than 6 months during reproductive years of woman life. Third is overweight or obesity due to body response to excess nutrient, whereby adipocytes become enlarged or new adipocytes are formed. Insulin resistance and hyperinsulinemia also can lead to obesity. Next is hirsutism, which is the presence of coarse hair in female at the face, upper lip, chin, upper back, shoulder, sternum, and upper abdomen due to excess androgen production. Lastly is acne, which is caused by hyperandrogenism, especially in adolescents during puberty. However, the exact cause of acne is still not confirmed.
My name is Wandurin Kusna Fatihah. Now, let's move to the treatment of PCOS. The recommended first-line treatment is combined oral contraceptive (COC) such as drospirenone and norgestimate with progestin and at least 30 microgram ethinyl estradiol. It is used to improve menstrual dysfunction and protect endometrium from hyperplasia due to chronic anovulation. The use of COC is continued for a few years and with help for 3 months to recover from the suppression of pituitary gonadal function. The next treatment is cyclic oral progestin such as Micronized progesterone. It is used to treat menstrual irregularities in sexually mature patients and useful in the patient without clinical presentation of hyperandrogenism. It is used for 7 to 10 days out of each month or cycle. The other treatment is androgen-reducing therapy. GnRH agonist therapy, such as dipod leuprolide. It can suppress ovarian function in patients who cannot tolerate or only respond partially to COC. During this treatment, it uses low-dose physiologic estradiol and cyclic progestin at-back therapy. Besides, start insulin sensitizing treatment for patients with insulin resistance and hyperinsulinemia such as metformin, because metformin has additional effect on reducing the circulating androgen level, weight loss, and improvement of regulation of menstrual and ovulatory cycles.
Hi, my name is Zixing. Now let's move on to non-pharmacological approach. First, weight loss can be done through dietary modification or physical activities. Strict control of carbohydrate, balanced diet with plenty of fruits, vegetables, whole grains, or limiting your calories. In terms of physical activities, Combinations of resistance and aerobic exercise for 45 to 60 minutes for 3 days per week for at least 12 weeks are recommended. Both can help to maintain healthy body weight and thus improving overall reproductive function. Insulin release will be reduced and insulin sensitivity can be improved. Eventually, androgen levels will be reduced. In addition, nutritional supplementation such as omega-3 fish oil can reduce total cholesterol, LDL cholesterol, and fasting glucose. In polycystic ovarian syndrome women who are obese, homeostatic model assessment for insulin resistance values can be reduced. Vitamin B8 reduces the total testosterone and androstenedione level, improving fasting blood glucose and insulin levels, and several other aspects. Therefore, vitamin B8 increases ovulation and thus increases pregnancy rate in women with polycystic ovarian syndrome. Moving on to the last question, which is the complications of polycystic ovarian syndrome. First, infertility and ovulation may occur. Besides, insulin resistance and obesity may cause increased risk of abortion and reduced rate of pregnancy because endometrial lining are more difficult to receive implantation. Next, obstetric complications including the risk of pregnancy-induced hypertension and gestational diabetes mellitus. PCOS women has at least threefold higher risk than healthy pregnant women. Lastly, cardiovascular risk, where increased risk of hypertension could be due to insulin resistance, hyperinsulinemia, or high testosterone level. Dyslipidemia might become worse along with obesity or by the syndrome itself. Estimated time of developing type 2 diabetes is within 2 to 3 years, and more than 50% of PCOS patients develop this within 10 years. Furthermore, obesity, which is common in PCOS patients, can further increase the risk of diabetes by approximately 3 to 4 times. Here is the list of references used in this case report. Thank you for listening.